Hey guys, it's Kyle, the founder of Dental Office Managers Community. And today we are on with Jamie.
Hey everyone, welcome to the Dental Office Managers Community Podcast, where we talk about the issues that matter most and help us to become better leaders in our dental practice. I'm your host, Kyle Summerford. Let's dive right in.
Jamie, thanks for coming on for the webinar. You and I had spoke over the phone a couple weeks ago, and I saw you in the group being super helpful to the community members with the perio coding. You're like super active in the chats, and once you and I connected, I figured it'd be a good idea to really put a face to the name and really, just introduce you to the community. And so we can kind of get a little bit more background info on who you are and how you ended up in dental.
Great. Thank you for having me on. I was like, I don't know who invited me, but somebody in the group invited me. And I kind of looked into it and I was like, sure, why not? And so here we are. And I appreciated you being so hands-on with noticing that I was giving my advice. And you wanted to know more about me and how I got this advice. Instead of asking questions, I think I was more of one that was giving answers as to what I know to be true based on my years of experience in this field and being a dental hygiene consultant.
Yeah. I mean, I saw how how involved you were, and I was like, who is this person? I was like, she's on a roll here. So anytime I see members helping each other out and things that I don't know myself, and I'm just like, wow, okay, this person really has a grasp on things. So I got to reach out. I got to find out who you are and really show you off to the group.
Oh, thank you.
That's how I look
I
at it.
appreciate that. I really do. I appreciate that. And my passion is making sure that we are educated in our field to the best of our knowledge and to the best of what I know is correct. It may not be always what you want to hear, but I do know that every single week I have some sort of a lawsuit that I'm hearing about out in our industry from an office that has been improperly coding and improperly documenting or not documenting. And so I don't know everything, but I know a lot because this is a passion of mine, is to keep our practices out of the courtroom.
Yeah, that's like the number one worry, right? I mean,
Mhm.
as an office manager myself, that's always been a concern. Is like, hey, am I doing this right? Let me get as much information as I can, really soak up the knowledge, so that I can make sure that I'm not get in trouble, and neither is the practice, right?
Yeah, exactly.
Because I'm the one entering things. So
Well, yeah, you're the right hand man or woman of the business owner. And so they just want to improve teeth and health and lives, and they don't really know a lot about this and this area, and so they just trust. And sometimes, unfortunately, they blindly trust. And at the end of the day, the person that is going to be showing up in the court is not and possibly have potential issues is not typically the business team member. It'll be the doctor.
yeah, so it falls back on the doctor anytime there's type of fraud.
Always does, because they're the practicing business owner, and they have to stand behind whatever was put or not put properly into the records that are in there. And number one lawsuit in dentistry right now is poor documentation.
Hmm.
It
Poor
used to be
documentation.
lack of, 15 years ago, it was lack of perio diagnosis. That was the number one lawsuit in dentistry. That's no longer there, and that's no longer the case. And so it is now poor documentation, and that usually comes from our notes and or lack of, and our poor coding.
Hmm. Wow. So how would office managers or insurance coordinators, whoever may be actually entering procedures into the system, How, like, what are some ways that they would want to make sure that they're not obviously committing fraud? Like, what are some helpful
Yeah.
resources or things like that out there?
99%, and I just want to make this very clear, 99% of what's put in accurately is not malice. It is just, I hate to say it, but a lot of it is um, old wives' tales, lack of them getting knowledge from somebody that got it from somebody else and got it from somebody else, you know? So it's that handing down of sometimes generational gaps. Our industry with coding and documentation changes every single year. So what used to work for somebody in the practice and was true, according to the AAD or excuse me, the American Dental Association and or the AAP, which is the American Association of Periodontology, does not work the same today.
Mm,
And so you have to stay on top of that. My go-to person, and this is not me trying to sell anything at all. This is not what you're about. It's not what I'm about. But Delane Galeggi, um, she is the guru of coding and knowing what the codes are used for and what they're not used for. And she and I are very close companions when it comes to this, because what I try to do is get my hygiene industry up to date. It's no longer good enough to just do your services and say, hey, I'll let the business team, handle that. The business team needs to know exactly what you did. They need to know you as a hygienist are responsible for making sure that you're coding things properly, because they're going to follow your lead. And so Delane and I have created a new workshop, just barely, where we have hygienists and business team members and doctors coming together. We're doing table educational forums, where you bring your own patients and or claims that have been denied, or if you're going through a lawsuit. Delane is a court appointed advocate for saying whether this is right or wrong. And so a
mm,
lot of my knowledge comes from me being in the industry for over 40 years, but a lot of it lately has come from partnering up with Delane Galeggi, because she is a wealth of knowledge. She is one that was with Charles Blair helping write all of the coding books. So she
mm.
knows her stuff, and she gets re-educated every single year on whatever it is that the board has changed for coding or added for coding. And honestly, that's your 1-2 source right there is her.
Gotcha. Okay, cool. All right. Well, that's good to know. So when you say fraud, right? Fraud it's like a scary word, right? It's like, ooh, fraud. So like what are things that you've seen that just might be, like you said, not malice, just unintentional coding when it
Mhm.
comes to like certain types of procedures?
Well, one of the main ones is that code of 4999, the 4999.
Unspecified. Yeah,
Yeah, unspecified.
unspecified. Yeah.
That is very much one that insurance companies are going after offices for. I've even seen on our chat line some people using that for laser, and it's not meant for laser. As of this year, we still do not have a laser code that is
Yeah. Yeah.
appropriate
It's
to
kind of odd,
use.
right?
Uh,
Kind of odd.
yeah,
It's kind of, you know, I want to jump in here just because,
yeah,
you know, it's kind of odd that, lasers are very common now, right? Like in the practice that I manage, we use a Solea laser. And the fact is, from my understanding, and correct me if I'm wrong, but the insurance companies don't necessarily care about what type of technology you're using, right? When it comes to like periosurgery,
yeah.
it's
They don't
more
ask you if you're using hand instruments or ultrasonics, right? So
right.
they're not going to ask you if you're using lasers. And part of the problem is that with that, from my guess estimate, my best estimate on this is that lasers is a gray area in most of the states. And
Mm,
so they're not going to jump on board with something that's considered gray. It's like you guys can use it however you want to reduce a pocket, however you want to get rid of the biofilm in the bacteria. That's on you. But doesn't mean that we're going to allow it to be a code that's recognized yet.
Hmm.
And so that was probably to me, what I've seen the most misused code is that 4999.
I see.
It's not meant to use it for, and I actually personally know of a hygienist in her practice in Arizona that they were using that for about 5 years. Arizona is very progressive with their uses of in hygiene, and the insurance company looked into the use of that code for lasers, and they had to pay back tens of thousands of dollars
Wow.
for misuse. And what happens a lot of times, not always, but then with whatever insurance company does their investigation, you will then be on a hold, so to speak, for them reimbursing you for any of your patients that have that insurance.
Wow. Oh my gosh. That's terrible. That's
Well,
a
and I'm not trying to scare. I just want to educate. It's like, and I'm a hygienist. I, I,
yeah.
I am not the code expert, but because I consult hygienists, I can't put my head in the sand about what's
Yeah.
going on out there when it comes to
Of course.
coding.
Of course. Yeah.
Yeah.
Yeah. Now let me ask you, how do you feel, or what is it that you would recommend? Because one of the common questions I've seen in the group is differentiating between LANAP, right? Uh,
Mhm.
and so how do you differentiate between billing for LANAP versus, a typical osseous surgery?
Yeah, that's another one in the gray area. And again, I'm only going to give my suggestions.
Yeah.
I
Yeah.
would
Yeah. Of
love it
course.
if we would follow up with Delane Galeghi on another um, coding interview.
Yeah. Yeah. Definitely.
But LANAP is also in that gray area. They're not cutting, they're not doing the osseous surgery, but a lot of doctors that it can only be done by a doctor, and they have to be certified in LANAP um, to be able to use it. But a lot of doctors are using that in place of osseous surgery um, until we get a code for LANAP.
Yeah.
I don't know where to go with this. I would just say be cautious. I would probably want to prove in my notes as the periodontist or the doctor who is certified to do LANAP. I would somehow want to prove in my notes that I was doing some sort of osseous surgery. I do have
Gotcha.
doctors that I've coached that do are certified in LANAP, and they don't charge it out as osseous surgery, the codes for that. They actually just put it down as LANAP, and they don't charge the insurance companies.
Well,
So again, it's a very slippery slope. And I'm
yeah.
not here to say what to do or not to do. But of course, the majority out there are using the osseous surgery code for the LANAP. But I know that can also come around and bite them in the rear end.
Gotcha. Gotcha. Yeah. That's the one thing we don't want to happen. So,
I
yeah,
think your documentation has to prove what the service code you used is.
I
So if there's
see.
some sort of osseous surgery that you can incorporate into that, then it would work. But your documentation has to. I cannot say this strong enough, but your notes have to back up your service code that you used. They have to match.
Yeah.
That's why one of the other kind of going down a different path right now, but a lot of offices will alternate an 1110 with a 4910. I highly recommend you don't do that because once a patient has been treated for periotherapy, having bone loss and having infection in their gums with bone loss, they are now a 4910 perio maintenance patient. Now, if the insurance company decides to downgrade that to an 1110, that's on them. But we have to document and prove that we did what we did. And so that 4910 code has to be proven through your documents that you are probing every single time with all points of bleeding and that you are doing something different than a prophy. Now, if they
Yeah.
change it, that's on them.
So Jamie, my question, I've seen this in the practice where I manage practice, and I've seen, patients that switch insurance, say for the new year. They've had osseous surgery done, say, November, December, and then they get this new plan in January, and you submit for a 4910 to that plan. But the insurance company comes back and they say, well, has this patient had scaling done within the last 2 years? And my question is this: if the patient has had scaling done prior to 2 years, what would you do to inform the insurance company to make sure that one, they can get this patient on the 4910,
Yeah.
coverage every 3 months?
Yeah. It's much like, good question, Kyle. It's much like a crown that's being replaced, an existing crown that's being replaced. And so if you, like in a specialty office, which I think you work in as a periodontal practice, right?
Yep.
A lot of times this happens to you, I'm sure of it. You can do a couple of things. I would always make sure that they've had any previous, whether it's non-surgical or surgical surgery done prior to come into your office. You would ask them the date of when they had, and you don't have to be exact. They don't have to say May 5th of 2022, but they could say May of 22. And you should be able to put that down in the form, where it says unusual services and remarks on
Yep.
your claim. You can put it in there, previous perio therapy or surgical therapy, whatever it is, done with a different provider, a different insurance company, and put the date. So put May of 2022, whatever it is, just like a crown. If that isn't sufficient, then what you need to do is have the previous doctor or office, if they can remember the name, we're talking under 2 years, previous provider, if they would supply the dates and the services either through a claim that's been closed or through their documentation of their notes of what they had that done. But typically just putting in a date as to when the previous was done right out of the gate, when you know that you're going to be supplying them with a service that would need that, for this new insurance company to provide benefits. Lots of times just a date will work, just like it does with crowns, pre-existing crowns.
Got it. Okay. So it sounds like you just kind of like give it to them before they get the opportunity to deny it.
So it doesn't slow everything down. Just
Yeah.
like a crown, an existing crown that you guys are replacing because of decay, you always have to say, when was the pre-existing crown placed? Same thing with perio. When was the previous periotherapy procedure done or surgical therapy done? And you would put that date in there, and you would just
Got it.
nip it off at the bud right at the top, and don't have to worry about it being denied and 3 weeks later, 4 weeks later, whatever, being finally okayed.
Got it. Okay, cool.
Yeah.
So, this is another hot topic, so to speak, in the group, right? D4346. That's that not so old code, right? It's not that old.
It came out in like 2017.
Is it 2017? Really? Wow, time flies. Okay. All right.
Nobody was using it. Now all of a sudden
Yeah, it's a hot,
It
it's
might
a
have
hot
even been
commodity.
2016. Yeah. Yeah.
So, can we talk a little bit about that?
Sure.
Okay.
Sure. Okay. So finally, the ADA recognized that patients just don't go from health, D1110, to needing a D4341 or 2, periotherapy. Okay. They finally recognized that. And so it was in hopes of that interim of patients who show that they're not healthy, but they have not lost bone yet. It's very, very important that everyone understands what the code is for. It is not a Band-Aid for hygienists or doctors to use to try to simplify the fact the patient needs to go through non-surgical therapy. It is not. So you don't use that at today's appointment. And then in 3 months, you're kind of planting the seed. And then in 3 months, all of a sudden, woo, they're a 43, 41 or 2. They will probably be denied. Bone loss doesn't happen that quick. Bone loss is a long process of the brain trying to help the infected area. And so to dumb it down, for lack of a better word, the brain is equipped to fix infection. It sends in the antibodies and it fixes infection. So we have a wound, it goes in and it knows what to do. But when it comes to the pathogens that are around teeth in the mouth, it can never fix it because the pathogens that are around a tooth in the mouth has to be disrupted mechanically. So that's by our instruments. That's by floss. That's by water picks. That's by our ultrasonic toothbrushes, whatever. That bacteria has to be disrupted mechanically. What happens when we have gingivitis without bone loss is that is the first attempt of the body saying, I need help here. But because the body can't fix it, the brain cannot send in antibodies to change that bacteria and make it go away. The body then starts to try to fight off the difference between what they think is the bad guy, which is the pathogens and the bacteria around the tooth, and the good guy, which is the tooth and the bone and the tissues. So slowly, the bone starts to regenerate, go away, because the body is trying to get rid of that tooth. Okay. So I know that's kind of dumbing it down, and I'm not trying to talk down to any of our listeners, but that is really important that you understand that, because once the body has lost bone, it now is a non-surgical or a surgical approach because it is migrated all the way into the bone. The gingival therapy is code, the D4346, was put in place in hopes of our hygienists doing something different before the patient loses bone. So it is a moderate to severe infection, bleeding, and it is generalized. So generalized is usually the biggest question is what is considered generalized. Well, I go by 30%. Now, somebody else that's a Delane or somebody wants to go out there, but I'm pretty sure she agrees with that. It's usually 30% of the mouth with no radiographic bone loss. So you cannot have radiographic bone loss. Now, the science behind us using our ultrasonics in every bleeding pocket is that we need 30 to 60 seconds in every bleeding pocket. You're going to get all kinds of comments about this. Okay, I'm just warning you right now. The science and the studies show that we need 30 to 60 seconds around every bleeding pocket in order to disrupt that biofilm properly and have to start all over again. So if a patient comes in today, let's just say they haven't been in for 5 years. They haven't been to a dentist, but they have no radiographic bone loss, but they got bleeding everywhere. They're on the path to losing bone, but we want to stop that right now. And gingivitis, of course, is reversible. But if I need 30 to 60 seconds in every bleeding pocket to do this properly, I need to diagnose today and I need to get them back. Just much like a patient comes in with a toothache and the doctor needs to do a root canal. 9 times out of 10, the doctor is not going to do that root canal right then and there unless they're in severe pain. They find an abscess, patient doesn't know they have it, and they find an abscess. The doctor will get them back for the appropriate amount of time in order to accomplish that root canal and do it properly. The same thing is with the D4346. After they go through the D4346, a full hour, not needing x-rays, not needing probing, not needing anything but the 30 to 60 seconds in every bleeding pocket, they would then come back in 3 months and you would reassess them 3 months in a day. They may be paying for this out of their own pocket, but that's okay. You just need to inform the patient. Okay. And they come back in 3 months in a day and you reassess their health or their infection. And if they still have more than 30% of bleeding pockets, then they go back through a D4346. If they have health or better health, then they would have an 1110. And then you would, if you felt good about it, have them come back in 6 months.
Okay. All right. That helps really clarify that code.
Yeah, it's
I
still a tricky one. It has changed. It has changed over the course of its introduction. It has changed as to what the gurus out there are recommending. It used to be that you started with an 1110 today, and then you got them back in 4 weeks for the 4346. The best thing you can do to get that code, get reimbursement for that code, is to take intraoral images and show the bleeding, and to also make sure that you have bleeding on any of the hygiene codes. You have to have your bleeding on your probe sheet. I do chart audits every single month for clients, and I will constantly see no bleeding on their perio chart, but on their notes, they'll say moderate generalized bleeding. We need to paint a picture. Every documentation that we submit to the insurance companies needs to paint the picture. So that includes your images, being able to see all levels of bone. So I highly recommend vertical bone X or vertical bite wing, excuse me. And you have to have your probe sheet show all any loss of attachment and any infection, which is bleeding, onto that perio chart. This is going to help keep you from having to submit your documentation, your notes. Because if they get enough of their answers met to approve it based on x-rays and based on their perio charting, they're not going to ask you to submit your notes.
Yeah. Okay, great. Yeah, one of the things I've seen time and time again is, you know, in me and myself, and what has worked for me, and it kind of falls in line with what you're recommending, is to really like throw the book at the insurance company, right? Just say like, hey, here's everything. I'm pouring it out to you.
Yep.
Um, take it, and do what you want with it. But ultimately, yeah, documentation. I try to do the same. Try to really
Yeah.
keep things in
And
line.
staging and grading.
Um,
Put in your unusual services and remarks, what their staging and grading is. Put
yeah,
down in that, you only have so many characters. I think it's 25. But depending on what you think that the insurance company may or may not approve, you want to give them, like you said, throw the book at them. And so staging and grading, maybe it's that they're a smoker, maybe that they are diabetic, maybe they have heart disease. And so they may have early periodontitis that needs to be treated that may be denied because they have 4 millimeter pockets with early bone loss. But they have bleeding and they're maybe, like I said, diabetic or something. You need to give that information to them as much as you can through the claim, which is what that box is for. I don't remember the number, how all the
35,
boxes.
35
Yeah.
remarks box. Yeah,
Yeah.
yeah. I know it because I'm always using it. So
Yeah.
you
Yep.
know,
That's what it's there for. And honestly, do whatever you can. And so, Kyle, you're exactly right. Give them as much information at the get-go, and that doesn't slow down your reimbursement from them.
yeah. Touching on medical conditions, you mentioned diabetes. One of the things I've noticed is, patients who have diabetes, um, and this has happened only once with one of our patients where, the mother actually had called for the son. She called the insurance company. This was many, many years ago, but I just wanted to talk about it because maybe some members may not be aware of it, and I wanted to get your take on it too. But because maybe there's like other medical conditions we might not be thinking about. But diabetes, like I said, I had a patient who the mother called the insurance company on a claim that was denied for a perio maintenance. And it was due to frequency. And the parent actually called the insurance company. And it turns out that the insurance company said, hey, look, if he has a medical condition, which the mother was explaining he does have diabetes, that he would be more eligible for multiple cleanings. And so this was news to me, right? I didn't know this at the time. It was just new information. And, sure enough, we had the doctor write up a letter, and we sent that letter off with the claim, and they ended up paying for that extra
Yeah.
cleaning. So, are there any other type of medical conditions that
Oh,
you
there's
know,
so many. this is what comes dear to my heart.
Okay.
And the reason I do what I do is the oral systemic link is because diabetes runs strongly in my family. Both my mother and my father died of diabetes, not before they lost limbs and went through kidney failure.
Mhm.
And my mom was in dentures by the age of 30 something, and my dad had many teeth extracted due to it as well. So it is a two-way street. So diabetes is just one of them. Back when I was started out in hygiene school, the only proof we had was the heart disease was high blood pressure and bleeding gums. So I need to go back again just a little bit if I can. That bleeding gums, no matter what age, is what creates havoc on our body. And if you are predisposed, I don't care if you're 25 years old, if you're predisposed through a family history of diabetes, heart disease, osteoporosis, arthritis, and various cancers, you have active periodontal disease, which is bleeding gums, not necessarily periodontitis yet, but you have bleeding gums, you are prone to having some of these genetic connections come to the forefront sooner than later because you have the genetic connection.
Mm.
So for instance, there's all kinds of studies out there right now on everything. I don't know what finally happened to our medical community and waking up, but they finally went, you know what? We haven't been able to find out a cure for cancer. We haven't been able to find out a cure for X, Y, and Z, low birth weight, low this, whatever. So finally they decided, oh, guess what? The mouth isn't its only, it's an organ on its own. The mouth is actually connected to the rest of the body. So luckily for us, this is what's so exciting about being our industry at this day and age, is that we have so many more of the medical companies now investing in doing investigation on what the infection, the pathogens, the biofilm in the mouth, and what it has to do with the rest of the body. So, for instance, colon rectal cancer, they're finding that in the tumors and the cysts that they're taking out from patients has a big, huge amount of the oral pathogens that are only populated within the mouth subgingivally. So they're finding that that is a big, huge correlation between that type of cancer and the bacteria in our mouth. Another one that they're starting to really look into is our patients who have dementia and who are getting Alzheimer's at especially early ages. They're finding that when a patient or a person is put into a home because of their dementia, and they do not get regular care every 3 months from a professional who's breaking up that bacteria, that the ones that aren't are getting an increased decline in mental health rapidly. So those are two that I've just heard of recently. They're right now looking into a glaucoma, not glaucoma, different vision problems, and they're showing that in the different vision problems, there's many of them, but they're looking into that. They're showing that the bacteria is also in a lot of these same patients. And you have to remember that this bacteria that starts below our gums is one of the few bacterias that starts without any reason. It just starts producing itself over and over again. It does not become harmful until it has been left undisturbed for somewhere between 8 to 12 weeks. That's why we do perio maintenances every 3 months, because it repopulates itself. And if a patient can't get to the base of a pocket with their floss or water pick, whatever, I highly recommend water picks. If a patient can't disrupt that, at least the hygienist and or the doctor would be able to get in there and disrupt that bacteria at the base of the pocket before it becomes harmful again. And so that's why when people say, well, I have a hard time with distinguishing between a prophy and the perio maintenance, you have to understand that what you do at the base of those pockets is something that the patient can't do at home. And you are there to assess a disease, which is bleeding. Everyone thinks it's pockets. It's not. It's bleeding. Bleeding is the disease, is the infection. And so you are there to assess the level that they're at. And you're also there every 3 months and a day to break up the bacteria that they didn't get to at the base of that pocket.
Hmm.
So I hope I answered your question as far as the other health conditions. But the reason I recommend a family history on the and anyone's personal history is one thing. Again, put that down in that box 35, did you say?
35.
Yeah,
35.
box
Yeah.
35, put that down in
Yeah.
there. But also, the patient may not exhibit infection today, but if you know they have a family history of those things that I just mentioned, just know that they're that much more prone to getting it and getting it quicker because they could have the interleukin 6 genotype from their parents that is related to a lot of the autoimmunes that are out there: lupus, osteoporosis, arthritis, periodontal disease, which, believe it or not, periodontal disease is a autoimmune, and various other types of things that I mentioned, certain cancers.
Hmm. Okay. Yeah. Thanks for summing all that up.
Yeah,
Wrapped it up in a nice little package.
good. Well, I hope it makes sense. This is what I do. This is what I do for a living. Every single couple of weeks, I'm on an airplane in somebody's office or on some stage, and I'm talking about this. It's a if you can relate these things to your patient, for me, for me, diabetes is my number one fear of getting, because I got tested and I have the interleukin 6 genotype high. Mine's high. So that means I was blessed to get it from my mother and my father.
Mm,
And
yeah.
so my biggest fear is to get diabetes. And I'm at my seasoned age, and I have gotten it yet. And I have to believe that part of that, of course, is my healthy choices, but it has to do that I'm in the dental profession, and I do know that unhealthy gums can push somebody who has diabetes into becoming diabetic sooner. And somebody who has diabetes, they are more prone to getting periodontal disease sooner, the
Hmm.
bleeding gums. And so if my hygienist were to say, or my dentist were to say to me, you go eat a rock every day off the street and that'll prevent you from getting diabetes, I'd probably go eat a rock every day.
Yeah. Yeah.
You know what I mean? Because that's
Me
my
too.
why. Because that's my
Yeah.
why. My why is I don't want to
Yeah.
ever get diabetes, because I saw what my parents did. They lived and died by the needle. They lived and died by taking their glucose level before every meal. They lost limbs. You know what I'm saying? So to me, that's my why. And as practitioners and as healthcare providers, we need to find our patients' why. It's not just because we can do what we can do. It's because why are they going to come back and spend more time and money in our chairs? And it's to help prevent them from losing limbs and maybe losing or going through kidney failure or maybe whatever it might be. But if we can provide them that service of breaking up that biofilm and keeping their health under control in their mouth, it's going to overall help them control the health throughout their body.
Yeah. Yeah. So I'll share with you that we do have something in common, and diabetes does run strong in my family as well. So I have the same fear that you have, and it's something that I've always really just, you know, took serious. Like, I don't want to
Mhm.
get diabetes. I got to make sure I make healthy choices. Because I don't want to end up with some things that I've seen right in the
Right.
family. So, you
Yeah.
know,
Genetics is
um,
a big thing that we can't change. We
yeah,
can't change ethnic background, and we can't change genetics. All we can do is take away the outlier, which is the bacteria, take that
yeah,
away from, doing that. So that's the only part we can control. And as healthcare providers, that is our job.
yeah,
That's our Hippocratic oath that we took. And unfortunately, I also worked in a periodontal office. And unfortunately, we don't get patients referred to us until they're at an advanced stage and the damage has already been done.
hmm,
And so
yeah,
we're just now trying to maintain them, when it comes to bone loss and periodontal disease and stuff. So I really believe that the general practitioners out there are my target, even though I work with periodontists too. And just remember, bleeding gums is not good. Just that's the thing. It's not because they have a 5 millimeter pockets. It's because their gums are bleeding.
yeah,
That's what we have to help them prevent. his bleeding gums, and they cannot do that at home.
Yeah, I mean, if we were bleeding anywhere else, it would probably be an emergency, right? Like,
Yeah,
you know?
I did this I did a video on it. My father, who's now passed away, but he had a pacemaker, and they had to replace it. It had stopped working, and so they were done replacing it, and they pulled me into the operating, like not in the room, but like where you look down at the room, the control
Okay. Hmm.
place. And they're just like, yeah, he's all done now. We're just cleaning him up, blah, blah, blah. And all of a sudden it was like code blue, whatever you call it, whatever it is. All of a sudden I saw the doctor back in there. I saw nurses in there. And it was because he was bleeding out of the place that they put the new heart pacemaker in. They
Wow.
couldn't get his bleeding to stop. They took that so serious. Like they were just like, and it was an incision this big. And they took that so serious. And why do we not take bleeding of the gums serious? I don't get it. And we can never change the mindset of America in our patients if we don't change the mindset first of us as providers. The amount of tissue in our mouth is the size of the palm of our hand. And if we had an open wound and bleeding the size of the palm of our hand, what would we do? We go to the eyeballs room.
Probably, yeah.
If my
Yeah.
eyeball was bleeding, I woke up, my eyeball was bleeding, I wouldn't say, oh, yeah, my eyeball's bleeding.
Yeah.
I'm sure it'll go away. No, we would run right.
Yeah.
So we have
Yeah.
to take it serious first.
Yeah.
Bleeding of any kind in the mouth is not healthy. So
Yeah.
sorry, I'm very passionate, as you can tell, about this.
No, I see it, and I love it, especially perio, right? So
Right.
yeah.
Right.
Yeah, I just kind of fell into perio. I mean, I've worked in practices where it was multi-specialty, everything under the sun. However, perio, I just, over the last, what is it, since 2014, so I'd say 10 years in perio. But before that, I was also, we had a periodontist in the office once a week. But I love perio. I think it's one of those things that the more you learn about it, the more you're like, ooh, ah.
Yeah.
You know?
It's very undervalued, the importance of healthy gums and teeth.
Yeah.
It used to be just to save teeth. In fact, my tagline is save lives one mouth at a time.
Yeah.
Because we don't need one hero. We need lots of people working in the same direction.
Yeah.
And that is to not overlook what bleeding gums means. And if we finally have a code, the D4346, and people are saying, well, they're not going to pay it anyways, or they're going to downgrade it. You know what? When I started back in dentistry, pit and fissure sealants were not paid for. It was a new code, but they weren't paid for. And look where we're at now. So we can't run away from using our gingival therapy code because insurances are downgrading. Let them downgrade it. But we need to use the proper service code for the services that we provided. And so please, people out there, do not run away from the D4346 code. The patient may have to pay out of pocket, but it's the right thing to do so that you have 30 to 60 seconds in every bleeding pocket. So anyways, Kyle, we could talk for hours.
Yeah. I would love to have you back on at some point. I know you're really busy. You have a lot going on, but maybe in the future we can bring you back on for a second round. Cool.
Get some questions, get some specific questions from our viewers and our people that are on your dental office managers community. Ask for some specific questions. Again, I don't know everything, but I do know enough to, the very last thing I'm going to say is that I see a lot in the questions is just because there is a code, it doesn't mean it's the right thing to use it. So use the code to match the services that you provided, period.
Right. Bill what you do, right? Bill what you do. Bill what you do.
But if there's other questions that anyone has, get them and then ask me to come back on another time. I'd be happy to.
Awesome. Thank you so much.
Yeah.
I want to wrap this up with just, what I've started doing with our previous guests is I asked them to leave a question for the next guest who's on the webinar. And so we'll make it. It's a surprise question, and so
Do you know who your next guest is and what their forte is?
so you're gonna share with me your question privately, but I'm gonna give you the question of the previous guest.
Okay,
and then you're gonna give me just a quick answer. I won't keep you on too long. But so the question that I have here is, if you were not in your current profession now, what other profession would you have chose?
Oh my gosh. That's a good question. I think I don't know that I would have done this back in my teens like I did, because I've been in dentistry since I was 17 years old.
Wow.
Yeah, it's the only thing I know. I sold shoes for about 3 months one summer.
Okay. All right.
So I know I wouldn't be selling shoes still. But knowing what I know now about my personality and my strengths, I would say that I would be some sort of a personal coach. I've only because I've been through a lot myself. And I believe that like maybe something like mental health. It's Mental Health Awareness Month right now. So probably something where I would try to help people find their value and their worth in this life, because I really feel strongly about that we all are of value and worth, and never give up hope, even though it may seem like a dismal place to be. So I'd probably do something in that arena, knowing what I know now and what I've gone through.
Wonderful. Okay. All right, Jamie. So thank you again for your time. Really appreciate you coming on here.
Thank you, Kyle.
We'll talk soon in the community.
Okay, sounds good. Thank you again for everything you're doing for our profession. I love that you have this forum. So anyways, I'll talk to you soon.
Okay, take care.
You too.